Good afternoon or good morning, depending on where you're tuning in. Welcome to APAICS inaugural Health Summit. I'm Madeline Milka, President and CEO of APAICS, the Asian Pacific American Institute for Congressional Studies. Thank you for joining us as we dive into a panel discussion on health equity and digital health. I'd like to thank our partners, American Cancer Society, Cancer Network, and GRAIL for supporting this panel. Before we begin, it's my pleasure to introduce Congressional Asian Pacific American Caucus Chair and APAICS board member, Congresswoman Judy Chu, who will be delivering remarks. Congresswoman Chu represents California's 27th district and is the first Chinese American woman elected to Congress. Congresswoman Chu is a tireless leader and advocate for our community, and we are excited to have her join us this afternoon. Please welcome Congresswoman Judy Chu.
Thank you, Madeline, for that introduction. And thank you all for joining us for today's APAICS Health Summit. I'm grateful to APAICS for organizing today's event and helping our country to better understand the unique challenges that AAPIs face in accessing healthcare. And the summit is especially important as we continue to face a global pandemic that has disproportionately impacted the AAPI community and exposed massive gaps and inequities in our healthcare system. That's why I'm so glad that our community has this opportunity to come together and discuss how we can tackle health disparities and expand healthcare access for all Americans. Even before the pandemic hit, AAPIs have had a harder time accessing care due to language, cultural, and geographic barriers. Because AAPIs are a largely immigrant population and 1/3 of our community is limited English proficient, many have faced barriers to accessing life-saving information and care due to the fact that much of this information isn't widely available in AAPI languages. On top of this, the disparities that AAPIs have faced throughout the pandemic have gone largely unreported due to a lack of disaggregated data that's often masked the challenges that certain AAPI subgroups are facing. But from the limited data we do have, we know that the coronavirus crisis has had a devastating impact on our communities. In just the first year of the pandemic, there was a 35% increase in the mortality rate of Asian Americans compared to the average over the past 5 years. And from December to January, there was a twofold increase in deaths for Asian Americans. On top of this, Native Hawaiians and Pacific Islanders are continuing to experience the highest COVID-19 infection and mortality rates in over a dozen states, including my own state of California, where the case rate for Pacific Islanders is 31% higher than the statewide rate. And despite pressure from AAPI leaders, 31 states still do not release data on COVID-19 deaths in the Native Hawaiian and Pacific Islander population, which means that these communities are missing out on vital resources needed to save lives and contain this virus. That's why it's crucial that AAPIs are fully included in our COVID-19 response, which is something that we in the Congressional Asian Pacific American Caucus, or CAPAC, have been laser focused on over the past year. And as a result, I'm so proud to say that in December, Congress passed an omnibus and coronavirus relief package that restored Medicaid to Pacific Islanders from the Compact of Free Association, or the COFA states. And just yesterday, Congress made huge history. We passed President Biden's $1.9 trillion American Rescue Plan. Not only does this bill help speed up vaccine distribution, send more stimulus and support to families, and help more businesses stay open, but it also helps close the healthcare gaps impacting communities of color. It provides $27 billion in funding to directly address minority health disparities and includes other measures to help ensure that everyone has access to healthcare during this deadly pandemic. For instance, it provides ACA subsidies for those on unemployment, provides almost $8 billion for community health centers, and almost $1 billion in training and support for doctors and nurses who serve underserved areas. And it includes $20 million for the Native Hawaiian healthcare systems, which provide critical access to health education, promotion, disease prevention, and primary care services for thousands of Native Hawaiians who've been hurt by the pandemic. Moving forward, we not only need to consider how changes to the healthcare system can address COVID-19 related health disparities, but we need to figure out how we can fix long-standing health inequities in our communities more broadly. The pandemic has forced healthcare providers to reimagine care, which has created an opening to address disparities within the AAPI community, including in digital health spaces such as telehealth, which is helping reach more patients at home than ever before. As a member of the Ways and Means Health Subcommittee, which has jurisdiction over numerous issues, including telehealth policies for programs like Medicare, I want you to know that I will continue to advocate that these services be available for everyone who needs them, regardless of your background, the language you speak at home, your immigration status, or your zip code. And that's why I'm so glad that APAICS is having today's panel to shine a light on health equity and digital health during COVID-19. I want to thank your moderator, Irene Bueno, Mr. Devon Adams, Dr. Eric Fung, Dr. Lan Duan, and Dr. Reynald Samoa, for their willingness to share expertise and guidance as we work to tackle this once-in-a-lifetime pandemic. Thank you.
Thank you, Congresswoman Judy Chu, for your remarks and your stalwart leadership. It is now my privilege to introduce Irene Bueno, co-founder of NVG. Ms. Bueno has decades of experience working in and with the highest levels of government. She served in the Clinton administration as Special Assistant to the President in the White House Chief of Staff's Office and Domestic Policy Council, and as Deputy Assistant Secretary for Legislation at the U.S. Department of Health and Human Services. A leader in the National Asian Pacific Islander American community, she serves on the Asian American Justice Center's National Advisory Council, the Asian American Action Fund Board, and previously served on the APAICS board. To audience members, please use the chat feature in Facebook and YouTube to enter your questions. Irene, I turn it over to you.
Thank you so much, Madeline, and thank you to the Congresswoman for your great remarks. I'm so happy to be back here again moderating a panel for the APAICS, your first health summit. So before we get started, I would like to introduce our very distinguished panelists. Let me first start with Devon Adams, who is a senior senior analyst for policy and legislative support at the American Cancer Society Cancer Action Network, the American Cancer Society's nonprofit, nonpartisan advocacy affiliate. At ACS CAN, he works on policy-related issues related to cancer research, device and drug development, and clinical trials. Devon leads the ACS CAN's work to improve access to biomarker testing in cancer and expand access to telehealth for people living with and beyond cancer. In addition to his ACS CAN experience, Devon has practiced as a registered nurse in critical, emergency, and public health settings and worked at the Healthcare Leadership Council, where he led HLC's telehealth and remote patient monitoring policy and strategy. Devon has a BSN from the University of Louisiana Lafayette and an MPH in Health Policy Management from the George Washington University. Next, I'd like to introduce Dr. Eric Fung, who is a Vice President in Clinical Development at GRAIL, where he leads several clinical development programs in support of the development of blood-based multi-cancer detection tests. Dr. Fung has previously held clinical development and R&D leadership roles at Affymetrix, Vermilion, Ciphergen, and Roche Molecular Diagnostics. Dr. Fung has led clinical trials leading to FDA clearance of multiple IVD products. Dr. Fung received his MD, PhD from Johns Hopkins University School of Medicine. Welcome, Dr. Fung. Next, I'd like to introduce Dr. Lan Duan, is a postdoctoral fellow in the Department of Population Health Section for Health Equity at NYU's Grossman School of Medicine. Her work is centered on the structural determinants of health and has focused on cardiovascular disease and psychosocial factors, including quality of life and depression among Asian American older adults, and how neighborhood deprivation modifies the impact of these determinants. She's an interdisciplinary scholar with expertise in analysis of complex data sets, with a focus on aging and aging-related processes, immigrant health, and social environments. Dr. Duan received her PhD in public health with the emphasis of health promotion and health behavior and minor in biological data sciences from Oregon State University. And last but not least, Dr. Reynald Samoa is a clinical research endocrinologist. He has a lifelong fascination with obesity-related disorders, and has parlayed that interest into research projects investigating the metabolic conditions that affect populations vulnerable to diabetes, such as Pacific Islanders and cancer survivors. Dr. Reynald Samoa received his medical degree from the University of Washington. He did his adult endocrinology fellowship at Los Angeles County University of Southern California, and his pediatric endocrinology fellowship at the Children's Hospital, Los Angeles. Dr. Samoa is a principal investigator on protocols aimed at uncovering the incident of immune checkpoint inhibitors associated diabetes mellitus in cancer patients, and a DPP-based lifestyle modification intervention for breast cancer survivors that have developed metabolic syndromes. So please join me in really recognizing this amazing panel. So I would first like to start off with you, Dr. Oh, I want to make some acknowledgments first. Today we will be having a conversation, but before we do that, I want to acknowledge that we will be using the acronyms AA for Asian American and NHPI for Native Hawaiians and Pacific Islanders in order to ensure that all of our communities are represented. Also, for those of you who are watching on Facebook and YouTube, we encourage you to use a comment section to ask questions that may arise during this discussion. We will get to your questions during the Q&A session. Okay, now, Dr. Samoa, I'd like to start off with you. How have telehealth advancements created better health outcomes for Pacific Islander communities?
I don't know. I mean, anecdotally, we can say that it has provided the gap that the increased risk of face-to-face appointments can incur. But whether or not they've effectively improved the health of the NHPI community is tough to say. I think before COVID, the data on Pacific Islanders and the quality of their healthcare wasn't very available. And I don't think much people besides Pacific Islanders really cared about it. And it isn't until now, when the rates are so high, demonstrating that NHPI have had, longstanding health inequities that have kind of led to their high rates of COVID-19. And now, when you want to see whether or not the tools that have been put in place to help COVID-19 are working, they're not. You can't jump from that immediately. You needed the foundation to do that before COVID. You needed a way to access whether or not NHPI populations are being treated at some level of parity with non-HPI individuals, and that information is just not present. And so anecdotally, it's been a mixed bag. There have been problems with language. There have been problems with cultural context. Cultural competency seems to be even more of an issue when it comes to virtual health. And I can only speak for Pacific Islanders. I wanted to be very clear that although NHPI is linked together, Native Hawaiians from the island of Hawaii have a very different experience. They have a different network, different safeguards, different providers, and they should be able to speak for themselves regarding that issue. Now, Native Hawaiians on the continent, their experience resembles more of that of the general Pacific Islander population. And so that's basically, my perspective.
Great. Thank you so much. And I have a similar question for Dr. Duan and Dr. Fang. How have telehealth advancements created better outcomes for Asian Americans generally?
I can start. So I think in similar lines to what Dr. Samoa said, the explosion of telehealth and digital health advances has created new opportunities to understand and really evaluate how healthcare is being delivered. And the purpose is really to ultimately create better health outcomes. So digital health can include health-related data infrastructures, and how robust these data infrastructures are has really foundational impact on the ability of researchers and the larger community to use data to inform policy and practice. So when I say data infrastructure, I mean things like electronic health records, so those electronic health databases, and using them to be able to track what clinical and non-clinical services are being provided and how they are being provided, so the context of how they're being provided. I think these digital health advances broadly also allow us to be able to understand whether they're being used to address the needs of the Asian American population, and more broadly, the communities of color, and will allow us to better track health access and usage across the tools.
Thank you. Dr. Fang, would you like to say a few words?
Yes, thank you for the opportunity. I think it's really about access, and I can think about two very specific applications of telehealth that really help increase access, and especially during COVID. I reflect on what my parents have done, which is use telehealth and teleappointments, and particularly during COVID, this is quite helpful option because of a lack of desire, obviously, to go into the clinic if one can avoid that. So access to sort of real-time healthcare is a huge benefit of advances in telehealth. There's another aspect that is more long-reaching, which is participation in research. And at GRAIL, we are revolutionizing cancer detection by thinking about how can we, at a population level, improve the detection of early-stage cancer. But in order to do that, we need to conduct studies that are really on the population health level and incorporate participants of all demographics, including Asian Americans and other kinds of demographic. And so telehealth, and we've actually employed telehealth in our studies, and this was really engendered by a need during COVID to really increase and broaden the reach of participation across a wide demographic group to help inform the development of these novel and groundbreaking technologies.
Thank you, Dr. Fang. My next question is for Devin. We know that detecting cancer and chronic conditions in early stages before it has spread throughout the body saves lives. Can you go a bit into detail why early detection is so important, especially for the AA and HPI community?
Sure, that's a really good question. And it's important to know with a disease like cancer, early detection before cancer has had a chance to grow and spread greatly increases a person's chance of survival. And we know that the AA and HPI community faces several cancer disparities or differences in cancer measures such as incidence and screening rates. For example, we know that the Asian community is the only racial ethnic group in the US for which cancer is the leading cause of death for men and women. And it's been this way since about the year 2000. This contrasts with other groups in America where heart disease is the leading cause. We also know that the AA and HPI community has some of the highest rates of liver and stomach cancer, which is about double that of non-Hispanic whites. And there's also data to suggest that screening rates are lower in some of these communities for cervical, breast, and colorectal cancers for which there's been evidence that shows that routine screening can really reduce death by early detection and linking patients to earlier treatments. We also know that historically we haven't had the best success at detecting some particular types of cancers in earlier stages. And I think Dr. Fung could probably speak to some of the work that Grail is doing in this department to really detect cancers earlier so we can treat them earlier and patients can have a better chance of survival.
Dr. Fung, would you like to?
Yes, thank you for the opportunity, and thank you for those insightful remarks. As Devin mentioned, the types of cancers that occur in the Asian community is somewhat different from what we see at the broad US population level. And as he indicated, cancers such as gastric cancer, liver cancer, and many virally related cancers are higher in the Asian population. And those are cancers that we don't routinely screen for using conventional guideline recommended screening. So there's a real opportunity to think about how can we expand the cancers for which we can screen for and hopefully detect at an earlier stage and improve outcomes. And this kind of benefit can be particularly increased if we can have a test or technology that has an opportunity for easy access. And therefore, a blood-based test that can detect a broad range of cancers, including these cancers that we do not typically screen for, has an incredible opportunity to revolutionize the way that we detect cancers and ultimately improve outcomes through treatment of these earlier stage cancers. And that's really where I think we can see far-ranging opportunities for improvement in healthcare.
Great. Thank you so much, Dr. Fung. So I am going to ask this question of all of you. So think about what your answers might be and who wants to be the first step. But the first question is, are there ways we can address AAPI health disparities with digital health and new healthcare innovations? Who wants to take that first?
Well, I can take a first crack at it. And where I see a lot of opportunity is, as I indicated, on two fronts. Clinical studies today are overwhelmingly populated by the Caucasian population. And for the findings in large population-based studies to be applicable across the entire population, we need a much more diverse representation. And telehealth and associated technologies can really help us, A, spread the word around these new technologies, B, provide opportunities to participate in these clinical studies, and C, actually act as a mechanism to enroll participants via the opportunity to collect the kinds of data that we need so that we can associate the findings in the study back out into the population. So the application of telehealth and incorporation of telehealth into broadening our representation in clinical studies, I think is a very important endeavor that we need to undertake immediately because it will have a long-lasting positive impact.
Mm-hmm. So anybody else want to add to that?
Just piggybacking off of what Dr. Fung just mentioned, I think that as we head towards this whole notion of decentralized clinical trials, that the advent of telehealth and digital health will really open up the opportunities to certain populations that haven't been traditionally represented in clinical trials to really increase the diversity and the data behind the science that's going on in these trials. So I completely agree with you that I see the angle of telehealth and digital health really, pushing clinical trials forward.
I'll take a stab.
Okay.
I think telehealth provides a very powerful tool to reach and engage communities, but that is not the obstacle in engaging communities. Pacific Islander rates of disease are poor, suggesting that our current health environment has failed them repeatedly. So it's one of those things where if you add a tool to a house that's already shaky, you still have a shaky house. Yeah. And so I think providing innovative solutions that engage community more effectively, such as what we're seeing right now with COVID-19, when the data wasn't available, it was community groups that went and prompted the reporting of disaggregated data. That's what brought out the flourish of high rates across the country And there's still a majority of states where they have a very large Pacific Islander community that work in agricultural industries that don't report data, and so the what we found to be very effective in reaching communities is letting communities lead, and providing them the medical guidance as well as the environmental awareness of the spaces they're entering into to do the work that needs to be done. So I don't see us doing much in regards to increasing equity without improving our ability to utilize the community in a more meaningful way. And so sometimes that means incorporating community health workers into your model, and finding better ways to do disease prevention. What we're realizing is that the distrust Pacific Islanders have with the medical community only utilizes them after the diseases occur. And there's a whole space of disease prevention that's being ignored with this group. And this is seen in, I think UCLA did a review of CHIS data that showed that the highest rate of prediabetes in California is in Samoans, and predominantly in young Samoans. And so I just don't. I see telehealth as being very, very useful if the infrastructure it's being used in is useful itself.
Thank you so much. That's really interesting that, that digital health will not be the panacea. We're going to still need people on the ground and trusted intermediaries to talk with communities, and we need to hear from them what works for them. Dr. Dewan, I think you might have some comments.
Yeah, I would agree with what the panelists have already said. To think about like the pandemic, there has really been a rapid shift towards digital health in the last year. And it has provided the opportunity for us to really examine how structural racism is embedded in like the larger digital health systems. And what COVID-19 has really emphasized thus far is that the data infrastructure is not working for our communities. To reiterate the importance of data disaggregation, so the last session, but also to Dr. Samoa's point, we need to collaboratively improve the quality, availability, timeliness, and also the details of the data that we're getting. So in order to better address the disparities that are happening, thinking about digital health literacy as a social determinant of health, we want health care innovations that are developed that are linguistically and culturally tailored tools for our diverse communities, which in turn would then increase community engagement with digital health. And this is an example where I think it's like a very low-hanging opportunity to have health applications available in different languages beyond just the typical Spanish and Chinese broadly. The Asian American community is so linguistically diverse, and just integrating translation services into virtual telehealth can really ease the language barriers. And I think similarly, also having resources and tools that are in language could really move the needle towards improving health. This was mentioned before also, but having people on site to provide these services to promote and increase digital health literacy among our community members. What that can look like is community health workers who are trained. They work in the hospital system, but also in the community settings. And they have a unique and really deep understanding of the issues related to digital literacy, access, whether that's access to devices, but also broadband internet. But they know how to engage with patients and key stakeholders. So I think this is really an opportunity for us to re-envision who is part of these conversations on digital health equity. And if our communities were involved in co-developing and really leading the efforts to developing these digital health resources and tools, we can ensure that the foundation of new digital health advances are centered on community needs.
Thank you, Dr. John. My next question, I think some of you have already addressed some of it, but we do see a lot of opportunities using digital health and telehealth tools, but what are some of the challenges? Like I said, some of you already mentioned some of them, but are there challenges using those tools to achieve health equity?
I can take this one. I think that we need to be careful as digital health becomes more ubiquitous and that populations who already experience inequity, that they're not left behind in this digital health, telehealth wave. Dr. Duan just put it perfectly. A big challenge is going to be digital health literacy, the ability to use and understand health information from digital devices. This can be even more challenging in populations who have limited English proficiency, older adults, or even have physical limitations to, seeing the device in front of them or, pressing buttons. All of these things can make it difficult for people to interact with digital technology in the context of a health visit. I think another challenge is going to be ensuring access to the tools that drive digital health and telemedicine. These are things like the devices, the broadband. I think we have to remember to include all of this as we see digital health, take a more prominent role in healthcare today.
Thank you. Does anyone else have a comment? I have one more question for all of you. So again, think about who wants to take it. Due to the pandemic, obviously patients have not been using the traditional way of going to see the doctors, making appointments, that they've been using telehealth tools. How do you see technology advancements make it easier for patients to access care in the future?
Well, I can start by at least talking about in the cancer screening world. And as you point out, Irene, during COVID, people attending guideline recommended screening has plummeted dramatically. And it's unfortunately a public health natural experiment that's going to be reflected downstream in increased number of deaths from cancer. And so technological advances that increase access to cancer screening, we hope can be utilized to reduce these kinds of situations in the future. Now, as we think about today, a scenario where we're screening for each cancer individually, so a person has to go in for a mammography appointment, which is separate from their colonoscopy appointment, which is separate potentially from their low-dose CT for lung cancer screening. And so you can see the sort of additive effect. And potentially, if we want to continue to think about options for detecting other types of cancers, it would be impractical to layer on test after test after test. And so a technological advance that I think will be very helpful is a single, easy to use blood test that can detect many different kinds of cancer simultaneously. And so on the cancer front, I think that that's going to be a huge opportunity.
Mm-hmm. Thank you, Dr. Pham.
I think one of the benefits of telehealth is the opportunity to bring more stakeholders into the visit. A lot of Pacific Islanders use somewhat of like a village approach to their healthcare, in that there's numerous, individuals that they would consult about a certain medical condition. For instance, I have family members who have cancer. Numerous of them have breast cancer. That they call me immediately after they have their visit with their doctor. And I would say about 3/4 of our discussion is translating what the doctor talked to them about. And then, on the same call is someone that lives like an adult child of theirs that lives 4 or 5 states away, that really makes the decisions for them. And so in the face-to-face world, it's very difficult to bring all those people of influence into one visit, which kind of goes against the way Pacific Islanders make decisions about their health. So I think telehealth in that regards can provide more cultural alignment with the medical system and the way Pacific Islanders make decisions.
Great. Thank you. Anybody else?
I'll add that telehealth also has the opportunity to kind of eliminate some of the structural type barriers. For example, you think of someone who may have issues with transportation to visit their doctor. That's one area where I can see telehealth really making an impact. Or even if you have an individual who can't take off from work or can't find the appropriate childcare to travel, across town for a visit. I think these are two kind of structural things that telehealth can address in the future.
Great, thank
I'll
you.
One last comment in terms of telehealth advances. So in addition to like virtual health, being able to address like structural barriers from getting people to the hospital or hospital settings, I think there's been innovations in like texting, chatting with someone online. So thinking outside just using a laptop for health services and care for people is an advance that I can see helping older adults, young adults, people who live in rural settings, so like a broad population.
Great, thank you. Okay, I have just a final question for all of you. Our theme at this Health Summit is to rise up to the challenges that we're facing after a year under the pandemic. So to wrap up our discussion, I would like to ask all of the panelists this question. How are AAPI and Native and Hawaiians rising to the challenge of health equity through digital health? Who wants to take that?
I can try. So there's a lot of efforts in trying to get more information to optimize our approach during COVID. Lan and I are both involved in a survey, a national survey that helps inform the Tri-Caucus about what the needs are in Asians and Native Hawaiians and Pacific Islanders. The other thing that they're doing is they're promoting awareness of what's available. You don't see a lot of people going onto the AMA website, the ADA website. They go to the trusted individuals in their community, and so where these efforts are being put forward to teach people about vaccines, to teach people about the latest recommendations. Koviki Talk, which is out of the Pacific Islander COVID-19 response team, they have a weekly seminar that has about anywhere between 4,000 to 7,000 views a week. And they talk about these issues to help promote understanding of telehealth and other things that are changed because of COVID. So there's a lot of ways the community is meeting this rise. And so I think it would be to the benefit of providers and healthcare systems to have these community people in their discussions about access to help optimize their approach.
Thank you, Dr. Samala. Would anybody else like to comment on that?
I would say just events like this, calling attention to the issues. I was able to attend some of the earlier sessions, and I think the more and more we keep talking about this, the more and more we keep engaging our lawmakers and bringing up these issues. It only serves to the benefits of the A and HPI community.
Thank you, Devin. Okay. All right. Well, go ahead, Dr. Dawn.
Sorry. So I would say also reiterating the point that Asian American and NHPI community organizations have been doing the work and rising to the challenge of advancing health equity during the pandemic and also pre-pandemic. Our community-based organizations have been providing critical resources, and they are the frontline health workers during the pandemic and really continue to be essential in addressing health disparities, which includes the role of digital health access. And I think a lot of the challenges mentioned during the session provide a space for us to expand the work to increase digital health access through more intentional engagement with communities who are most impacted. And similar to comments that have been made throughout the Health Summit, in order for us to sustain the community impact, we need federal, state, local policymakers and also legislation to invest in our communities. who really do understand the important connections and intersections between advancing health equity and efforts needed to improve digital health equity.
Okay, well, thank you so much for that. Now we have some questions from the audience. The first one will be for Dr. Samoa, so get ready. Let's see, here is the question for you. Are there any ways we can use extenders such as community health workers through telehealth to create one better health outcomes for PI communities?
Yeah, there are many different ways. Let's start with just the traditional sort of face-to-face role. There's linguistic translation and there's context translation. When you have a community health worker that's particularly trained in a certain disease entity, such as diabetes, they oftentimes can help translate content that isn't that's not commonly translated word for word. The other ways community health workers provide a significant resource is in things like diabetes education or diabetes prevention. So, diabetes, the DPP program, which is now, CMS, now that it's reimbursable through most insurances. These programs have gone to the wayside during COVID because they were basically group-based programs that were face-to-face. A lot of these programs are being, translated into the virtual space, and it's prime real estate for a community health worker that has good standing with the community to provide that kind of diabetes prevention. And so also with like vaccine information and dissemination, having people group together so that they can you can translate information through a community health worker. That's another way you can optimize the virtual space and community engagement and outreach. And so, yeah, that's just off of the top of my head. There's actually like a ton, and I'm sure Lan can tell you more since they have a lot of experience with it as well.
Yeah, I was trying to write notes of other things our community workers do, and this will not do them justice. So for those who don't know, community health workers are also like promotores. Other things that I could think about is their role in providing non-clinical services. So if we're thinking about COVID right now, community health workers have been able to provide people information, like real-time information on anything that has changed regarding COVID, the COVID vaccine, how to get testing, and it's really specific to their geographic region. So again, helping improve access to healthcare resources. In addition to clinical services, community health workers have been instrumental in providing non-clinical services. So that's how to access health insurance, where to go to get translated materials, to even access testing sites. But health insurance and public services, access to those is really where I've seen the community health workers, their very important impact.
Yeah, just to tag on to what Lance said, the community health workers that have been affiliated with the response team have helped with food distribution, rental assistance, utility assistance, and because they're community health workers, they generally have their ear to the ground when it comes to community resources. And so a lot of these community health workers serve on our regional task forces. So they're privy to what, like Lan said, vaccine sites, testing sites, any type of resources regarding travel. Those have all been very useful for a provider such as myself to be able to refer patients and community to someone who's in the know.
Great. Thank you so much. sounds like community health workers are really a lifeline for a lot of individuals who are not normally, involved in the larger society or have some, have some challenges accessing assistance. So thank you. Okay, and the next question I'm going to ask this, all of you can answer it, but I'm going to start with Dr. Fang. Here's a question from the audience. How can we close the digital divide for some communities that may not have good internet access, such as rural communities?
So we've given a lot of thought about how to work with our rural community partners. And I think that there is actually an interplay between the conversation we just had, which is the community workers who, are much, unfortunately, can be quite dispersed. And I mean that in a good way, which is to say that they have access to a lot of these communities that it's actually fairly challenging for, centralized organizations to reach. And so really having a good communication with these workers who are out in the community and leveraging their relationships to actually act as a conduit. We talked a little bit earlier about access to translated materials and other types of collateral that's actually critical for engagement. And so I do believe that there is an opportunity, and we have to leverage the right resources to make sure that we can work with our rural community, which in point of fact, as we think about at a population health level, they are often the last ones to get access to the critical types of technology advancements that we've been talking about today.
Devin, same question to you.
I'll just add that this is something that has definitely been recognized by policymakers, and there's a lot of federal efforts going on and being talked about right now to increase broadband access to our rural communities to make sure that they aren't left behind in the digital divide, and there's no digital divide that's created. I just think that unfortunately, it's going to take some time for everyone to get connected. And I will add, is just as far as digital health and telehealth, I think there needs to be a real push for digital health literacy. I think I maybe mentioned this in my earlier remarks as well, but really just meeting with these communities and showing them how to use these technologies and identifying what barriers that they could potentially come up in the use of these technologies is going to be really, really important so that people aren't left behind.
Thank you, Devin. Dr. Dewan?
I would add to Devin's point, I think it is really important to have free and accessible high-speed broadband internet. I know that there has been legislation on that. There's also been efforts to provide community hotspots at libraries or public spaces. Other efforts are providing devices, but we know that's not the answer because devices get old. Applications may not be downloaded on these type of devices. So I think thinking, again, outside of the box of what we think of as digital health, so not just computer usage, we can think of texting, making sure that telephone lines are available in whatever advances are made, so that texting phone is also an option as a solution.
Sounds like layering is important.
Yeah.
Dr. Samoa?
I hate offering solutions outside of systems and environmental change, because not to say that these potential solutions that are being offered aren't important. It's just that it's very tough to implement these without a full evaluation of all the obstacles that come with digital health. And so my recommendation is to put forth a framework somehow. There are models out there that are effective in looking at obstacles to access, and a lot of them are being used by communities, and they're being shepherded by some community-based organization, and they're using things such as the CDC Change tool to get a very good sort of a look at the environment and what things need to change. It helps prioritize the needs of the community as well. That being said, it doesn't have to be led by a CBO, if you will. It can be led by community health clinics. It can be led by private office, anybody who has a care about improving care in the community, you can make these system changes. And so my recommendation is to use that approach so that you're not band-aiding solutions without input.
Thank you. I think we have one more question. For this one is for Dr. Fang. What are some of GRAIL's strategies for providing equity among different AA and NHPI communities?
Yes, so that's a great question. Our view is that a technology such as a blood test that can detect multiple types of cancers is a great start, but it really depends on access to that technology, first of all, and then second of all, the types of education required to make that test useful to a broad population. And so there's both the inputs and the outputs. So I alluded to the inputs earlier, which is to say that we have active engagement and active endeavors in broadening the clinical research portfolio that we have that incorporates many more AA and HPI population, as well as rural communities. The second is that we have programs that are looking at some of the cancers that particularly target the AA and HPI population. So for example, we are looking at hepatocellular carcinoma, so liver cancer, which is outsizely represented in this kind of population. And then the third element is really education and working with our partner stakeholders to provide the education about what are these advances and how they can be helpful and what their benefits are in a public health perspective.
Thank you so much. Okay, those are the questions that we have from our audience. So I think we will move into, believe it or not, the closing statements by all of you. I hope you've enjoyed yourself. I know I have. So I'm preparing all of you. Devin, we're going to ask you to go first, but we'd just like you to, in a minute or so, minute or two, give some closing remarks before we end our session. So Devin?
Sure, and just thanks to all my panelists. You guys really gave some great remarks today. I like to close with just by saying broad telehealth and digital health use is here to stay. I think over the last year, we've seen the value it can bring, especially during a global pandemic. Advancements in digital health have allowed for many face-to-face encounters with patients and their healthcare providers to be supplemented, or in some cases even substituted, with visits that enable providers to deliver quality care and quality clinical services at a distance with options like video conferencing and remote monitoring. However, I really think we should be thoughtful on how the use of these technologies evolves to ensure that it doesn't create or exacerbate any health disparities, especially among vulnerable populations with limited digital health literacy, and populations that live in rural areas and in racial and ethnic minorities. So I just really think that we should focus on this going forward so communities aren't left behind.
Thank you so much, Devin. Dr. Fang?
Yeah, so I really appreciate the opportunity to participate in this panel today, and it's actually been quite enlightening for me as well. What I would say is, and I return to my opening remarks about access, and really when we think about any technology advance in healthcare, and telehealth being one of them, it's all about access. And there are underlying structural elements within our society that we need to work on to help promote that access. So the question is really, how do we utilize telehealth, which in its core, like any other technology, can be both beneficial and harmful? And so how do we ensure that access is available and the quality of that access is equitable? And those are where we need to work with policymakers, with our community health workers, and with technology companies to ensure that there's a 360 view on how we can move forward.
Thank you, Dr. Fang. Dr. Dewan?
I would reiterate a point that I made earlier about re-envisioning what we're doing right now to really include communities as part of this conversation on digital health equity. Again, if our communities are involved in co-developing and leading these efforts, then we can ensure that the digital divide is not exacerbated, and again, that future advances are centered on community needs. And I'll end with thanking my fellow panelists and then also APAICS for organizing this summit.
Thank you so much. And last but not least, Dr. Samoa.
I too want to offer my gratitude to APAICS for sponsoring the summit as well as this section of it. I'd like to say that there's a sentiment that indigenous wellness and technology are opposing forces, when actually one can be used to enhance the wellness of all communities. And so, the digital health will help bring about health equity when the systems allows for it, and so deconstructing these systemic racist infrastructure has to be a vital part of making digital health be a part of that. And so I hope our conversations become uncomfortable. I hope they become more profitable, so that we get to a better state than we were before COVID. So thank you once again. And thanks to my fellow panelists for joining everybody today.
And I just want to thank all of you for, taking time. I know it takes some preparation to prepare for these kinds of panels, and I appreciate all your preparation and sharing your expertise. I know I learned so much. I think sometimes we might think of digital health or telehealth as, using your computer, but I think that all of you brought out something that really relates to what's going on every day. Dr. Simone, you talked about we need this infrastructure, we need a system. You can't just build upon that, because having the best digital health system on top of a broken house, I think you said, just will not get to where we need to go. And, we know we need to get to health equity, and that these are the tools that will help us to get there. But we have to make sure we have the infrastructure. Dr. Dewan, you said we need to have the dialogue with the community to make sure they're brought in and that they are part of it. And Dr. Fung, you talked about health equity is access, and there's innovations. I know I'm waiting to get my mammography because I'm nervous about going into the doctor's office. But if there is a blood test that we can take to find out, to do our screenings, that would be incredibly helpful. And then Devin, you're a policy expert. Please make sure that the issues that were brought up today are part of the dialogue when you're talking to policymakers on the Hill or state and local governments, because this is so important to make sure that the voices of the Asian American, Native Hawaiian, and Pacific Islander communities and our experiences are brought to the table. So thank you, APEX, for holding this really important session and for asking me to moderate. And I think we're done. So thank you so much.
Thank you.